So hello, welcome to Conversations with Connie. Today I have a very special guest with me. Her name is Tara Hood. I have had the pleasure of knowing Tara for some time now, and I love the work that she does. She's actually quite compassionate. But today Tara will introduce herself because I want to make sure she's comfortable with information's out there. But also, as we sort of move forward, it really is looking forward to just having a good conversation with her about providing healthcare behind the wall. So welcome, Tara.
Thank you, Connie. Thanks for having me. As you said, I'm a nurse practitioner, a family nurse practitioner. I have been in corrections for approximately 10 years, and I work in a women's facility. And I am also a retired member of the Connecticut Air National Guard. So I'm a veteran also. So I think that kind of helps in my role working in corrections in terms of working with custody staff. So that's been a blessing.
Nice. So do you feel that like having a military background made it a little easier for you to transition into the role in corrections?
Yes, I mean, I don't know what it's like to be in corrections and not have a military background. So for me, it was kind of like everybody was speaking the same language. Because as you know, corrections is, very strict and almost paramilitary in a way. I don't mean that in a negative connotation. I just mean that there are rules and regulations that you have to follow. And that's what I was very accustomed to being in the military. And so for me, it was like hand in glove. I was picking up what everybody was putting down, and it just seemed to coalesce a little bit easier for me.
Got it. So how exactly, tell me a little bit about like what a day in the life of a medical APRN behind the wall looks like.
Sure. We, come on the job, go through, the Sally Port, and get to my office and look at my schedule for the day and see who's coming for appointments. I also review lab data from the day previous, usually, going through that with regarding patients' blood work, x-rays, anything that may have come back. And then if there's any abnormals, consider adding those patients to the schedule to notify. Well, yeah, that's typically what we do, is call them down if they need, follow-up or medical care or whatnot. And making sure that custody is aware of that I don't work in a vacuum in that regard, that I don't just call a unit and say, hey, can you send inmate so-and-so to outpatient medical? I have to, inform the chain of command, inform the custody staff that I need to see this individual also, so they're made aware. And then the custody officer basically calls down my clinic as the day progresses, and we see clients based on whatever their medical complaint is for that day. So if it's for a sick call issue, we see them for a sick call issue. If it's for a follow-up for chronic medical condition, then we do that in terms of, diabetes, hypertension, things of that nature. We also respond to emergencies within the facility, and whether it's a inmate code or a staff code or anything like that, we respond.
So what does it look like when you have like a list full of people already established, and then you get labs back that have some significant finding where you then have to add those individuals to your call down list for the day? Does it help that you have a pretty decent working relationship with custody, or does it make it more challenging because you're adding people to that list?
It's a little bit of both. It really depends on, every custody officer is different. the good thing about our facilities, they tend to have the same custody officer on a rotation. So they get accustomed to who we are. They get accustomed to working in an outpatient medical environment. And so it ends up being a little bit more collaborative, I want to say. And they want to work through all the different provider lists to get patients seen. And so it doesn't typically end up being a problem. The only issue that we ever typically run into is if there's a facility recall or a lockdown or some situation like that. And then we typically have to utilize the chain of command to have the lieutenants help escort a patient down, depending on whatever situation is also happening in the facility.
Nice. Okay, so I mean, I think, the audience will be great to know, like, sort of what that process is like. But I also think it's important to understand that as a provider, there's a certain way you provide care. And sometimes, or just providers in general, right? Mm-hmm. And sometimes there's this struggle between being the advocate and undue familiarity. Could you talk a little bit about that? How do you find that balance of still staying true to yourself?
Mm-hmm. Sure. In terms of advocating for the patients, so from my role, it's pretty much primary care standpoint, and to determine whether or not inmate patients can stay within the general population, or if they need to be receiving a higher level of medical care, either in our infirmary, our inpatient medical infirmary, or at a local emergency room. And so that is the crux of our issues. So in terms of boundaries and undue familiarity, I don't really see an issue with that, because I advocate for patients based on their medical need, not based on who they are. It's all about like boundaries that you have, that I would have with patients in the community. I would have the same level of boundaries. And I'm just trying to wrap up what I'm trying to say. It's just, there's no like, hey, how's your family? That's doesn't even come on the table, in a patient, inmate patient visit. And it's just.
Do they ask you about your family? Do you find that they try to get personal?
It has happened on occasion. I mean, I was pregnant with my youngest son during my tenure in my position, and so inmate patients that have left and come back, they'll say, "Oh, you were pregnant last time I was here. How's the baby?" And I would say, "Oh, fine," but I don't say he's fine, she's fine. I would say, "Doing well, thank you for asking," and then that's the end of it. We move on. In terms of advocating and having those boundaries, if they need to be admitted to the infirmary, or see a specialist, for example, if somebody needed to go see a cardiologist or a dermatologist or whatnot, I would follow the same standards of having that person see a specialist that would be the same in the community. So just because they're an inmate or an incarcerated person, it doesn't change my approach to making sure that they're seeing the specialists that they need to see based on their medical condition, not anything based upon provider relationship or anything like that.
Got it. So I think a lot of times, I know that I've had, inmates write me letters and they want me to do all these things. Like, as a provider, how do you manage the sort of grocery list of things that inmates come in with? Your list may have you seeing them for one thing, but what do you do to sort of hone in or focus that visit?
Mm-hmm. Yeah, that's a great question, because a lot of times when it's difficult to get an appointment with a provider after their initial assessment. And so When inmate patients come for an evaluation, say they come for their chronic medical condition, but then all of a sudden it will turn into 2, 3, 4, 5 conditions outside of what their complaint was initially. And so I try to reformulate the visit, reframe the visit into, you're here for this medical condition today. I will address, a couple more issues based on the severity of how it's impacting your quality of life or whatnot. And then some of the other things, I refer them to the commissary list so they can purchase over-the-counter medical items to help supplement some of their conditions. Like if it's back pain or whatnot, we'll have a conversation about OTC meds and how that can be helpful, and diet and exercise and weight loss and selection of meals off of commissary. The core abdominal muscles, strengthening those. And those are things that typically patients don't want to hear. So once I start talking in that, making it a little bit more encompassing, then they're like, okay, all right, I'll try that. Yep. And then because they know that that's what they need to do. And then I also will schedule them for a follow-up visit to address the other items that I didn't get to.
Okay, good. So, you and we talked a little bit about methadone maintenance and what that looks like in the facilities. And, there are some people who really feel like MAT is bad. Would you be able to explain a little bit about MAT and the benefits? I know that there's other options like Suboxone or Vivitrol, but what are some of the benefits that you would say come with methadone maintenance?
Yeah, so MAT is, it's a little bit, it's more encompassing now. It's medication assisted therapy. There's a detox portion of that. So if somebody came in an acute detox from opiates, then to place them on a regimen to get them off of opiates in a safer manner. And then there's medication assisted therapy in terms of long-term care. And so I think that there are a couple of schools of thought in regards to that. My opinion is not the opinion of the employer that I work for in any way, shape, or form. I think from a MAT standpoint, it's typically methadone, Suboxone, and then naltrexone, which is an injectable, also known as Vivitrol. And for inmate patients that are coming into the facility, the nursing staff does a really great job in terms of doing the health screening on patients and determining if they're in a program, contacting that program, and then following the guidance, the policy for continuing with methadone if they came in on methadone, continuing with Suboxone if they came in on it, and whatever else the criteria is in terms of if they're sentenced, unsentenced, their bond, if their urine is clean or dirty, meaning it has other agents, street agents in the urine, and whether or not the provider, not necessarily myself, will continue with MAT during their incarceration.
Got it. So, I guess I'd be remiss if I didn't ask about our management of communicable diseases and infectious diseases. I believe that we've always had standard protocols, and those are the protocols we'd always follow on any disease or any outbreak that we've had in a facility. Mm-hmm. Do you find that we've done anything different in the management of COVID-19?
Oh, for sure. COVID-19 is on the tip of everybody's tongue with every conversation, whether it's with inmates, with employees, with leadership, with the general public. And so we, from a health services standpoint, I think did a great job in terms of having an infectious disease provider, having an infectious disease nurse, being able to track infections and whatnot. And now with the addition of COVID, having weekly meetings, deep cleaning of the facility, what do you call it? The PPE for staff and for incarcerated members, and it's just constantly hitting home and reiterating the need for frequent hand washing, infection control procedures, reducing the spread of infection, hand hygiene, the sneezing, coughing into the elbow, a lot of education for the population, which has been great.
And so that's something that we've had enough support of. And, I think that certainly in the beginning, a lot of facilities reported back just the shortage of PPE and like needing direction. But would you say that we were better, or you were better positioned because we already had sort of the infectious disease nurse in place? We kind of had some protocols in place already?
Yeah, I would say. And then there's been a very close relationship with the facility staff, the custody staff, and the central leadership in making sure that everybody is protected, because nobody wants to get sick. Nobody wants to be that person that brings this COVID-19 into a facility. So everybody has a heightened awareness of the importance of infection control, I would say, at this standpoint.
Okay. So I wanted to talk a little bit about leadership. I mean, we talked a little bit prior to, and sort of the implications of not having leadership available sometimes. How do you, as a provider, navigate, I guess, these waters without necessarily having all of the support you might need? Or is there some other way that you get support and training outside of what's immediately available to you?
Mm-hmm. Yeah, I think that being in this role behind the wall, as you call it, as a nurse practitioner, it's very, how do I say, it's very daunting at times, because in the beginning, I thought I would come to corrections and I would lose a lot of my skills that I had as a nurse practitioner in the community, because I'm leaving behind all the best modern technology of MRIs and CAT scans and labs immediately at my fingertips. And in reality, it makes you a better practitioner, because you have to become more resilient on your skills and in your own knowledge of what you've been taught, and your ability to assess and diagnose and treat accordingly. And so when service models change in terms of regionalization or whatnot, and if I'm the only, or if people are off and I'm the only nurse practitioner there, or if my colleagues have different specializations, then I can reach out to the facility staff who's there, my colleagues, and then also reach out either via telemed or a simple phone call, and talk to leadership that way. And nursing leadership is excellent too, because they are helpful in terms of making sure that the nurses are there to assist the providers and help get us what you need. So I'm sorry.
So would you say that you usually have a nurse to support your clinic?
No, I don't have a nurse to support the clinic, but we do have like a mini triage nurse. Not the nurse isn't mini, but triages patients that come down, and the providers have a pretty good working relationship with the nurses, because they're the eyes and ears of the facility from a health services standpoint. And so if they say, hey, I need you to see this person, then it's like, yep, no problem, because they typically have a very good sense of what's happening to a patient when they come down.
So I wanted to talk a little bit about the correctional nurses. Like, I feel like they are truly rock stars. And I say this because, you know, some days they're running short. They don't have much time to take a break. They're constantly going. And on top of that, you could ask, well, my experience has been, I could ask any of the nurses a question about anything, and they would either know the answer or be able to get me that answer within no time. You know, is there a way you feel or you think that we could provide more support to the nursing staff?
Yeah, I mean, I don't work in a leadership role in terms of overseeing nursing staff or staffing matrix or anything like that, but definitely I feel as though there's a shortage of nursing within the facilities. Not only what I'm trying to say is, in general, correctional nursing is not one of those desired professions that everybody raises their hand right out of nursing school and says, oh, I want to go work there. You know, most of the time they think like they want to do ER, ICU, or med surg first and don't ever consider correctional nursing right off the bat. So, but I think reframing, and I think the profession as a whole has been doing that, reframing correctional nursing in terms of population that they're serving, providing nursing care to the underserved, having it be more of a public health type of nursing position is definitely has been changing on the landscape. I think, you know, having nurses in abundance is always a good thing because, you know, like I said, they're the eyes and ears of the organization. And so there's never not a need for a nurse, in my opinion.
I agree. So now, what made you decide to come into the correctional environment?
Yeah, that's a really good question. I think I was given a job posting for the position, and I read it and I was like, nah, I'm all set. And then I would read it again, and it was very, like I said, it's very independent. It's very much an austere environment at times. It was very second nature to being in the military and having being like in a deployed type setting, because you're taking care of patients that in an environment that doesn't have a lot of supplies and things there. So you have to be on your game all the time, and you have to trust in your skills and in your training. And so I like that. So, and you know, it's yeah, I'm sorry.
No, that's good. I mean, for me, I think it's always good when you know your why. Like, why am I here? Why did I come into this role? Why did I stay? Why do I stay? Right? Like,
Yeah.
And sometimes people struggle with the why.
Right.
And as the more I think about it, you know, like you, when we talked earlier and you kind of just said, you know, like you're not in corrections, but you kind of are. And, it, you know, for me, the why is I really enjoyed what I was doing in corrections.
Mm-hmm.
I think that the work is meaningful. And I do think the population needs people who want to be there. I think they need people who can see beyond the inmate, right? And see that this is a person, and this person from a health services perspective is in need of care or whatever it is they need. And we provide that because they're already doing time for their crime. It's not for us to in any way, you know, hurt them any further, do any additional damage. So like, I think the knowing the why is always a good thing because then it kind of just justifies your existence.
Yeah.
And then so I think, go ahead.
I was just going to say, so I actually interviewed and turned the job down. And then a week later, I woke up and I told my husband, I think I'm going to take that job at the prison. And he said, what are you talking about? You already told them no. And I said, yeah, I know, but I just feel like I'm led to go there. And he goes, it's not how it works, honey. That's not the real world. You don't just turn down a job and then call them back and tell them you'll take it. And so I was like, all right, well, we'll just see what happens. And I did just that. And they were like, what? You want to come here? And I was like, yeah, I feel like I'm supposed to be there. And so when you were saying about your why, you know, when I see an inmate in my office chair when they come in before they sit on the exam table, you know, it's but by the grace of God that is not me. You know what I mean? That I could be sitting there. And so I think of that. And also, these women are so not addressing their medical issues when they're in the community because they have everything else happening, that there's a lot of pathology in this population. And that tends to come out when they're removed from their environments and they're able to seek medical treatment. So I think that's a little bit of my why, both of those things, that I'm supposed to be there, and that I see a lot of pathology and I'm able to provide the education and the care that you know I'm supposed to provide for patients.
Thank you. I mean, I think one thing I was thinking about that we didn't talk about at all is, so when you're having an encounter and the patient's in your office, like, has there ever been a point where you felt afraid? Like you felt like, you know, something's going to happen to me. And then if you thought about, you know, just feeling uneasy or what have you, what did you do in that time?
Yes, I've had a few occasions where the hair on my neck stood up, where I could sense that something was going to happen. In one occasion, I did have an inmate, you know, come at me. And then following, you know, once everything was settled down and I saw the patient and follow up a few weeks later, she apologized, you know, and said, Tara, I'm so sorry. I would never, I was off my meds. I would never hurt you. And I was like, well, you came pretty close. And
Wow.
she's like, well, I just wanted to apologize. And I said, all right, no problem. Thank you for apologizing. So
in that incident, did we have custody come and get involved?
Oh yeah, for sure.
Do you have like a body alarm or any way of alerting someone that something was wrong?
No, our phone, if it goes off the hook, then it rings to the control. And then outside my office door, maybe 20 feet, there's an officer at the desk. So I just yell out the door and they come.
Nice.
Promptly, yeah.
Well, I mean, Tara, I can't thank you enough for sitting with me, having this conversation. I really want to make sure that it was something that there was no edge on it. It was just really just understanding from the medical perspective what it is to be a provider behind the wall. I think it's also, you know, just very important that, you know, we're able to really just talk about like our experiences. I think we don't talk about them enough, you know. So for me, the Civilian Corrections Academy has really been just a platform for civilians to, one, be recognized, but also for civilians to get any support that they need and just know that there's so many other civilians working in the system that could be a resource to them. So like, I'm so thankful that you were willing to come on the show and just talk about what it was to be a provider. Is there anything that you would want to say to the audience before we go?
Yeah, I don't want to leave it on a bad note in terms of the feeling, the prickly feeling that something was about to happen. I do want to say that a career in corrections is very rewarding in terms of the patient population that you're treating from a provider standpoint and from a nursing standpoint also. I would not write it off as not glamorous enough or no satisfaction or whatnot, I definitely would recommend any of the listeners who are considering a career in corrections to seriously consider it, because it is rewarding and it is fulfilling. It is exhausting on the same token, because there's a lot of inmates that are looking for medical care, and they have a lot of comorbid conditions. But it's a great opportunity, and I'm just very thankful that I chose to call that director back and say, hey, I think I'll take the job.
Well, thank you so much. And, hopefully we'll have you on again soon. Maybe we could talk about some things more in detail, but I certainly just am so grateful that you were able to come on tonight and make some time for us.
All right. Thanks, Connie.
So, yes, it was definitely good talking with you. And, till next time, everybody stay safe.
All right. Take care.